Okay, so welcome everyone on board. So in our like effort to just have a quick review of anesthesia in last 1 week, we have done neuro, obstetric, pediatric, uh, and liver, thyroid. What else? Yesterday we did respiratory system, and before that also cardiovascular system. So today we will just try to have a quick conceptual review of what regional anesthesia is. Okay, so um, uh, whenever we want to give any anesthesia, we always try to either we have to give a general anesthesia, okay, or we will just try to have a sort of anesthesia in which we are able to anesthetize the patient without making the patient fully sleep, okay, or other you can say that maybe a little bit of sedation, but mainly with a block which is giving the motor as well as sensory blockade, and the surgery is being done. This is one aspect of regional anesthesia, and the other aspect of regional anesthesia is part of general anesthesia, or part of what we say it as multimodal analgesia. Okay, so this is the second domain or second aspect of regional anesthesia. Okay, so we will just try to get a conceptual way that what are the basic things which you should be knowing when you are uh, understanding regional anesthesia. Okay, so yeah. Okay, so mainly regional anesthesia is one we say is the central neuraxial block, and the other one is the regional anesthesia with reference to lower limb or upper limb or trunk, okay, or abdominal wall. Mainly, we are dividing as like this, and the other part is some of the, you can say, sympathetic blocks which we are, or you can say some blocks which are related to chronic pain therapy. Okay, so today our domain will not be for that one I will try to have another session because that's a specialized domain, and usually it's not being asked in the normal anesthesia exam. So I will just try to have a concept of pain maybe tomorrow or any other day in coming days, but the mainly like this. So there are basic things whether you are giving even central neuraxial block, or you are giving any other upper limb block or lower limb block. The basic thing is that how you are achieving the block. So the main thing which is we are giving is local anesthetic. Okay, so there will be certain properties of local anesthetic which should you should be aware with reference to that, how quick the onset, the duration of action, okay, trying to avoid the toxicity, or if toxicity occurs, what are the thing by which you can avoid the toxicity, and what you do if toxicity occurs. Then another aspect with is onset, duration of action, and then the quality. Okay, that whatever block you are giving, how to improve the quality, and how you are choosing a certain block. Okay, then what are different techniques? Okay, techniques means that what are different ways you can perform it, and what are the you can say endpoints. I would like to use this word endpoints, and how you are using, like maybe you are using it only by palpation, okay, and the surface landmarks, and then you are giving it, or you are using ultrasound, or you are combining some palpation, surface landmark, ultrasound, and even the nerve locator, I would say, nerve locator, and also image intensifier, the C-arm. Okay, so these are usually various techniques by which you are giving, and endpoints mean what happens. So you guys, whatever block you are giving, usually there are three components. One is sensory, other is motor, and other is autonomic. Usually these three components, some of the components will be very obvious in certain blocks and some will be less obvious, but usually whenever we are giving a regional anesthesia, these three blocks will be occurring, and these are the basic concepts you should be knowing. So for example, if you want to increase the onset of action, so you should be knowing the basic pharmacology of local anesthetic, that they are weak bases, okay, and the basic theory is that they are going inside the cell and the nerve cell, and they are blocking the action potential. Okay, so you need unionized drug, unionized drug, because whenever we are giving this, it's a combination of ionized and unionized. So the basic concept is of pKa. Okay, so pKa is a concept, is a hypothetical concept. It's not a static concept. It's a dynamic concept, and whenever we are trying to understand that, there will be a balance that in which unionized versus ionized portion, uh, the more amount is in unionized portion. Okay, so when more drug is unionized, you can say it is nearer to the pK, because pK is at the pH at which the drug is 50% ionized and 50% unionized. Okay, so for example, the pKa of lidocaine is around, in some books it's written 7.8 or 7.7, and bupicaine is 8.1. So it is nearer to the physiological pH of 7.4. So if a drug you are using is nearer to that physiological pH, the more unionized portion will be there, and you will achieve it quicker. So if you compare lidocaine versus bupicaine, so lidocaine will be quicker. The reason is this one. Okay. So there will be certain things by which you can achieve this by adding it bicarb. Okay. So if you are adding bicarb, you are actually, cause the commercial preparation which are there are usually acidic. And the answer to the question that why they make it acidic, basic solutions are unstable. So usually the commercial preparations are acidic. You will just recall it is written lidocaine hydrochloride, bupicaine hydrochloride. So the reason of this is that these solutions are acidic, because acidic solutions are more stable, and so that's why. So when they are entering in the blood, or they are entering in the body, they are having like equilibrium is achieved. So if you add bicarb, this equilibrium will be achieved in quicker way, and the effect will come quicker. So this is because whenever we are giving block, whether it is central neuraxial block or whether it's any other peripheral nerve block, this is the thing which you need. That if you want a motor block, or you want to have a surgical anesthesia, you want to get it quick, because surgeon will not give you that much time. That's why we try to make a combination of lidocaine with bupicaine whenever we are trying to achieve this. Okay, so this is the reason for it. Of adding bicarb. So this is one point. The other point is that how you calculate the dose. So usually different books will have different. So I'm concentrating bupicaine and lidocaine. Ropivacaine is also there. Prilocaine is also there in certain blocks. That is the component which is actually obsolete now. It's never being used in a normal anesthesia setting. That is IVRA, intravenous regional anesthesia. Yes, people are still being asked in the exam, but practically with the use of ultrasound, practically, I'm telling you, practically in safe anesthesia practice, I don't think so it is any more used. Yes, some people will argue on this thing that still IVRA they are using it, but actually it's matter of experience. Practically, if you have ultrasound technology with you, you don't need to give IVRA with reference to hand or something, because it's not a, it's never a safe thing practice to do, because any time sudden tourniquet, even if you are using a proper tourniquet, there can be mistake and it will lead to local anesthesia toxicity. So dose, usually it is 2 milligram per kg, okay, of lean body weight usually. And for bupicaine and for lidocaine, it's around 3 to 5 or 5 to 7 with lidocaine, with epinephrine. Okay, so here few words about epinephrine. So why we put epinephrine? Epinephrine is for two reasons. That sometime it is being used to identify IV, drug going IV. This is one use. And the other use is that it will cause local vasoconstriction. So not only it will prevent the toxicity by decreasing the absorption, and it will also leading to a slightly prolonged effect. So these are the utility of taking epinephrine. Okay. But because bupivacaine, for example, already is slightly longer acting, so the utility with reference to prolonged action is not there too much. But still, epinephrine, when you are adding it can prevent toxicity by decreasing the absorption, because wherever you are putting the drug, ultimately it has to go in the blood. Okay. And the concept is of uh, toxic blood levels. Okay. Toxic blood levels. The concept is toxic blood levels. So wherever you are injecting, whether you are injecting for brachial plexus block, or whether you are injecting for intercostal nerve block or for epidural, the absorption will be different. And ultimately, the important thing is actually sometimes not the dose. It's the absorption. Okay. So if any point of time the drug is suddenly absorbed in the blood, okay, by anything, because we are working in a blind way and we exactly don't know what is happening to the drug, but if somehow it is absorbed suddenly, it can cause toxicity. That's why ideally it's not safe to give any regional anesthesia without intralipid. Okay. But of course it depends on the scenario where you are working, but it's, as a safe anesthetist, you should not give a block when till the time you don't know where is intralipid. So because suddenly absorption, you have calculated the dose, you have given, you are very happy that you have not crossed the toxic level, but still it can cause toxicity. Okay. Because it's not the dose, it's the toxic blood levels. Mind this concept. Toxic blood level is the thing which you should be knowing. Okay. This is another concept. Then volume. Okay. Certain amount of volume, because the dose will be one thing. Like for example, I'm just giving you example that you calculate that 100 milligram is the safe dose. Now you have to divide that 100 milligram in that volume which is required. Usually, even whether it is epidural or peripheral nerve block, usually forget, remember the word 10 to 20. Usually all the blocks we are giving is around 20 ml. Okay. So 20 ml is the amount usually you are giving for this for block. Okay. So you have to divide with the concentration on in your mind. Usually for surgical anesthesia, you need 0.5%. Okay. For surgical anesthesia, you need 0.5% of bupivacaine. Okay. For analgesia, you can come down even to 0.0625, or usually because making preparation 0.1% is easier. Okay. So usually we prepare 0.1% for analgesia and 0.5% for anesthesia. Okay. And sometimes the things are in between. Like you are giving a block, you in number of blocks, you are giving 0.25%. Okay. But remember one thing, that you have to be careful about the volume, and you have to careful about the maximum safe dose. So this would be the first step. Okay. This would be the first step when you are giving a block. Of course, I have missed one thing. You have to inform the patient the consent, inform consent, explanation, the limitations and possible complications of the block. You have to tell when you are taking the consent. So whenever you are taking the consent, you have to be very careful. And another, before you poke the needle, you have to do the WHO surgical safety checklist. Okay. Because there are incidents, even I myself have done block on the wrong side. So this is a happening which you can then which you can do anytime. Okay. So WHO surgical safety checklist along with this consent issue. This is also a common thing for anyone. Okay. So coming back to the point which I was discussing, the toxicity, the toxic dose, the concentration, and the volume. Okay. And the safe dose. So these are basic concepts. Then bicarb, as I explained to you, that when you add bicarb, the solution becomes slightly basic, and the pK, the drug pK will be achieved in a better way, and more unionized portion which can pass through the nerve cell membrane to block it. Okay, so this is the basic concept. Now some other adjuncts which people add. One of them is, for example, dexmedetomidine is one adjunct. Opioids is another adjunct. Okay. And people add a lot of things. Okay, dexamethasone is another adjunct. We will just quickly have a look what advantages we can get. Like opioids, they are given to reduce the sometimes they can slightly reduce the requirement of the local anesthetic, but it also improves the quality. Okay, it improves the quality of the block, and especially if you are giving intrathecal, you have to give a medication which will remain inside for a longer time. So the drug which is the one which good for intrathecal, if, of course, if there is no risk with the delayed respiratory depression, morphine is the actually the intrathecal opioid, because none other is as effective. Because for example, people are very fond of given fentanyl. Unfortunately, fentanyl is so much lipid soluble, it will go out, so it will not remain for a longer time as compared to morphine. But morphine, intrathecal morphine is there, it's very effective. Another important thing with reference to intrathecal specifically is that the whatever drug you are injecting should be preservative free. Okay, yes, practically, this is only, again, remember one thing, in the exam you will never use, but I'm just telling you a practical concept that some people say, and I will quote one of my one of my colleague here, my senior colleague. He told me that this one concept is preservative free, and the other concept is that you just look at the preparation and see which preservatives are being used, and then you can search online that whether this preservative is safe or not. Of course, practically you should not try. Okay, but because I have seen him using dexamethasone, and then I try to understand how he is using, because it's not preservative free, but he's using it. So then I understand this. Of course, this is only practical concept, that you can search that whether that preservative is not doing any bad thing bad. But again, this is not a safe practice 100%. And this is not for the practical exam purpose. This is sorry, not for exam purpose, this is only for practical conduct. So these are few words. Opioids will improve the quality of the block, and can increase the duration of sensory block, not usually motor block, and it is improved. Similarly, dexamethasone is also, the mechanism is unknown, but it also increase the duration of the block. And actually, practically, I have faced used it in brachial plexus block, and the duration was prolonged for a long time. So dexamethasone also prolongs the duration of the block. And even one nice morning, I had a very terrible experience that even after 24 hours, even the motor effect was, and I was having a lot of tension. Even patient was not able to have more. So this was an exceptional longevity of the block. Usually it does not happen, but actually I have seen, practically I have seen. Then dexmedetomidine is also increasing the quality and increasing the duration of the block. Practically, another practical experience I'm telling you, that dexmedetomidine and dexamethasone, even if they are given IV, dexmedetomidine or dexamethasone, even if they are giving in the solution, or if they are giving IV as infusion, dexamethasone as IV, it also has some of the same, because I have practically used like that. And I have, but because there is limited data available for this finding, that whether you can achieve the same results with the not using in the solution, but actually practically I have seen it, because dexmedetomidine is actually as a multi-dimensional medication, it gives that. So this is another important point. Some of other adjuncts, people use ketamine also, but I don't have much of the experience or much of the knowledge about it. But usually these are the adjuncts. So the concept of dose, concept of volume, concept of this what are the adjuncts. Okay, so now coming, so how to avoid nerve injury. Okay, this is another concept you should be. Clonidine, unfortunately, it's brother or sister of dexmedetomidine. It will have almost the same effect. Okay, there you will find, there is an article on adjuncts in neuroaxial anesthesia or adjuncts. So you can find a lot of data with the reference to exam. You can say usually whatever adjuncts we are adding, either they are providing us safety, Either this is to delay the absorption, either it is to decrease the requirement of local anesthetic, or it is to improve the quality and duration of the block. This is the answer which you can say. And but you can don't nobody, this is not like you can say that this, they will not ask you more detail than this. Okay, because opioid fentanyl, we are using it frequently, it's a time tested thing, and they can, yes, they can ask you what are the complications. So intrathecal opioids will cause more of pruritus than if they are giving IV. Okay, especially morphine, it causes a lot of problem if you are if the patient is relatively sensitive to the effects of the opioids. So this is what because, and another, remember one thing, the all these medication will ultimately be absorbed in the blood. So the same effects which are there when you are giving IV or intramuscular or subcutaneous or intradermal, whatever, ultimately all these things, all these garbage is entering in the blood, and the liver is the one who is metabolizing these medications. Remember, so never forget that you have put in subcutaneous or you have put neuroaxial, whatever, ultimately they were. So any problem with liver or any problem with kidney, you should be thinking about it, that ultimately they have to be excreted. So any active metabolite, like morphine, if you have given intrathecal in a patient with liver failure or renal failure, you can predict that there may be delayed respiratory depression in that patient. Okay, so you should not forget this thing. So I'm just giving you a concept which, remember one thing, the main landmark is not at all a problem. You will be caught in the safety, the do's and don'ts. Okay, so now I'm going to the next step of the thing, nerve injury. Okay, whether you are giving central new axial, whether you are giving any peripheral nerve block. So basic thing is that you should have a good concept of the landmarks. You should have a good concept of the surface anatomy. Okay, and variations. This is important thing. Then you can use ultrasound to locate the nerve. This is one thing. Locate either the nerve or the compartment. Okay, because there is another concept now, compartment blocks, like erector spiny block, like tab block, like quadratus lumborum block, even paravertebral block. It's sort of compartment block. You are not identifying a proper nerve. You are just giving medication in a compartment. Okay, in some way intercostal nerve block is also sort of, you are not identifying the nerve. You are injecting in a place where you know that anatomically there are nerves. So it's also sort of compartment, but it's a limited compartment. Tab block is a bigger compartment. Quadratus lumborum block is a bigger compartment. Erector spiny block is a bigger compartment. Even the PEX block, the PEX block or serratus interior block, okay, these are compartment blocks. Okay, so you should be knowing that wherever you are injecting, either it is causing direct nerve injury or with reference to of course, the absorption. Okay, with reference to absorption. So you are using these gadgets of ultrasound. So locate it. Okay, then you can use the nerve locator. Yes, ultrasound, another, with reference to central neuraxial block, you can identify where is midline. Where is midline? Okay, what level you are in. You are thinking, you are very happy, I put my hand and it is L3 L4, but it is L2 L3. Okay, and the data suggests that in only 1/3 time you are at that level. When you put your hands on this iliac crest and you are expecting that it will be L3 L4, only 1/3 time you are at that level. Majority of time either you are one level up or one level down. One level down, no problem. But if you are one level up already and now you want to go one level up, so maybe you are touching L1 L2. So this can create problem. So always be cautious, and I'll never try to go up because you don't know where exactly you are. So if you want to know, you can use ultrasound to measure the midline, to measure the level you are in. And the third thing is to identify the distance between the skin to the space. Okay, so as much, maybe after 5 to 10 years, maybe ultrasound will become a point of care to get these answers before doing central nervous block, even whether you are giving epidural or whether you are giving spinal. Yes, of course, we all are lazy, but I have seen with my own career in my own career that maybe 13 years ago, when I came to Saudi Arabia and I started using ultrasound for the first time in my life, there was only one consultant who is my academic father. He used to use ultrasound even in cardiac anesthesia, and other people used to make like they used to not very too much impressed by him. Okay, but now you know that nobody would like to have CVP or arterial line in different difficult cases without use of ultrasound. And rather, ultrasound is point of care or recommended to use in CVP. If you do CVP without ultrasound and you create a complication, you are not covered medically legally. It's nice. It's a nice guideline. So maybe after a few years, this will also become a point of care in regional anesthesia also, that you should use ultrasound even for locating the midline, measuring the level, and measuring the distance from the skin to the space. Okay, so three answers you should be knowing, even with you have given thousands of spinal, but you are not sure where you are, so you are doing in hit and trial. Okay, so this is important thing. And when you are identified, you can go either median or you can go paramedian. Okay, because I will just few words about paramedian. That advantage of paramedian is that sometimes there is ossification of the ligaments. So paramedian, you can identify the space in easier way. Number one, there are less, theoretically, there are less chances of PDPH. Okay, there are less chances of PDPH with paramedian. Yes, there are more chances of vascular tap, or there are more chances of paresthesia because the nerve roots are coming out, so you can touch them. But practically, I love paramedian approach, and maybe you can say that more than 50% or 60% I would say of my in my career, central neuraxial block, especially spinal, I have given paramedian rather than median. Okay, so this is one another point. And another advantage is that when you are going through midline, you are damaging the ligaments. So how good your hand is, how good, how small gauge needle you are using, but still the needle pass through the ligaments. Okay, so there are chances of ligament injury, and ligament are avascular structures, so they take more time for healing as compared to muscles. Okay, so when you are going in paramedian, actually you are going skin, subcutaneous tissue, paraspinous muscles, and then you are entering ligamentum flavum, and then you are entering the epidural or either dural. But when you are going midline, you are going passing through supraspinous and interspinous ligament. So they may be a cause for post-operative backache. So these are 3 points I wanted to tell with reference to this thing. And now the so ultrasound using nerve. I'm coming back to that thing which we are discussing. So ultrasound to identify the nerve or identify the compartment or identify in the neuraxial, and then you can use nerve locator. Okay, so you will use nerve locator to see the proximity. If you are intraneural and you are injecting, it can cause nerve damage. Okay, so intraneural injection, you can not 100%, there is no way, by the way, no way 100% to avoid nerve injury, but these all combinations, ultrasound, landmark, ultrasound, and then also identifying it with Doppler to see the vascular structures nearby, and then proximity with the nerve stimulation, that if it is coming around 0.5, it is ideal. Even if it is stimulation is coming at 0.3, you need to pull out a little bit because maybe you are intraneural. So these are the things which you should be knowing, whatever block you are giving. So you should be knowing these things. Got it? So, and the other things which we have already discussed, the concentration and toxicity. So these are very important concepts you should be knowing. So up till now, we have covered a number of major concepts. GP is doing thoracic segmental spinal for laparoscopic surgery. I have no idea about it. I will never recommend anyone to do this thing because it's not safe. It's dangerous. Okay. People are doing it. People are doing a lot of things, but you never tried. I can tell you, can you even think of giving 30 milligram bupivacaine, 30 milligram bupivacaine in spinal? I know many people who do this. Maximum of 20 milligram I have done, but 30 milligram I cannot even try. 20 milligram, up to 20 milligram in a strong adult, I have used it with very good effect, especially if you are giving using for unilateral, or like you are using it in a prolonged surgery in which there is no significant risk factor of too much hypertension. Okay, so don't go for such things which are not safe. People are doing it. I agree with this point. Okay, so some maybe I'm missing anything. Anyways, let's go to some other points, and if I remember anything which I have missed, I will come back. So now, how to choose different blocks for lower limb surgery or upper limb surgery or trunk blocks. Okay, how to identify different things. So let's start with lower limb. That if you have a certain blocks which we can use, one of them is femoral nerve block, okay, obturator nerve block, lateral femoral cutaneous nerve, okay, then saphenous nerve, the big boss sciatic nerve. Okay, so the basic concept is that you have to block these nerves if you want to have full anesthesia or analgesia of the lower limb. Okay, usually if you are giving femoral nerve block, you can say there is a concept of 3-in-1 block, okay, or you can use sci-fi block. This is a little different from 3 nerve block. This is suprainguinal fascia iliaca block. Okay, so in which you are going with the same techniques, the same thing, but you are going suprainguinal, and it is giving better pain relief in hip surgeries. Okay, hip surgery. So one block is sci-fi block. You can read details about it, but I'm just giving you a choice because I have discussed, by the way, individual surgeries with individual nerve block before. So you can, if you like this discussion, you can open the playlist and you can listen to the rest which I have done before. Okay, so sci-fi block is one of them. Then another is uh, Inna lillahi wa inna ilaihi raji'un. I forgot the name. Another block which, because I have not used it number of time, it will come back. It will come back. There is another block which bang block. Okay, posterior nerve group block. This is also for hip surgery, but here lateral femoral cutaneous nerve you have to block separately. Lateral femoral cutaneous nerve will not block in bang block. Another, because this is relatively superficial block, so it is relatively easy and it is relatively safe. I would say people do it. People, I have not done it frequently, but people do it pang block, and actually it needs, you have to touch the bone. So I found it a little tricky. Some people who have got the good experience, they are doing it. So remember the word and you can explore it. But pang block, you need to block lateral femoral cutaneous nerve as well. Okay. So now coming to this, the traditional 3 nerve block for like above knee amputation. If you are doing above knee amputation, you need to block both femoral nerve and obturator nerve and sciatic nerve. So you have to give a combination of both the block. With any technique of sciatic nerve block, you need to block sciatic nerve and you have to block these nerves. Okay, even if you are doing below knee amputation and they need to put a tourniquet, you still need to block lateral femoral cutaneous nerve of thigh, because tourniquet pain will not be covered. Hip surgery, pang block is for hip surgery. Okay, for hip surgery. Okay, so lateral femoral cutaneous nerve is required for hip surgery. Sorry, for tourniquet. For tourniquet, for any. Then uh, uh, some words about knee. So knee, actually, there are certain techniques which are being used for motor sparing. So one of them is adductor canal block. Okay, and again, you know, you became short of memory sometimes. There is another block, maybe I will just recall in few minutes. There is another block which is in addition to the genicular nerve block. Genicular nerve, there is another block which is being used for the sensory motor sparing blocks for knee. Otherwise, you can give femoral nerve block. Femoral nerve block, and even sciatic nerve block to have full anesthesia for so full analgesia, even post-operative pain for knee surgery. Otherwise, one is adductor canal block, genicular nerve block. There is another block. I will just recall its name. Anyways, so these are for, and the foot, of course, the famous our pericapsular. No, not pericapsular. Its name is something else. It's with the with the bone and artery. So I don't remember the name. It will come. It just slipped out of my mind. Okay, the ankle block with 5 nerves. 4 of them is the component of the sciatic nerve, and the only component is the saphenous nerve. Okay, so this is the basic concept. Whenever you are doing, so you should be knowing the dermatomes, you should know the myotomes, and you should know the osteotomes. Okay, pericapsular nerve is a novel regional technique that can be used to reduce pain after hip surgery and fracture demodex. Yes, it's night finding. Okay, if someone can Google the block for motor sparing block for knee replacement, or but otherwise I will need to open to search. I that it slipped out of my mind. Okay, these are the basic concepts we should be knowing. And remember one thing, whenever you are doing any lower limb surgery, there is one thing, the site of the surgery, and one thing is tourniquet. So you should remember, don't forget to cover the area for tourniquet, because maybe the surgery is in the foot, but they are putting the tourniquet and you should cover the tourniquet pain. Or they are doing below knee amputation, but the tourniquet is upstairs. So you need to put the block in which the tourniquet area is covered. Otherwise, there will be pain. Okay. So saphenous nerve is on the medial side, and the sciatic component is on the mid to lateral side. So these things you should be knowing about it. Okay. I have intentionally missed one component. I will try to, because we have still have 20 minutes, and I will try to give as much information about regional anesthesia. That is the coagulation. Okay, the coagulation and the blocks. I will try to give the last 5 minutes or few minutes for these important things. Okay, so before that, I will try to cover the some of other aspects. IPAC. Yes. Okay. So this was the block which I was not recalling. It is in what is the abbreviation for? I don't. I this it slipped out of my mind. So IPAC block is the one which giving for motor sparing. Okay, you can write the abbreviation here. Okay, so similarly, the summary for upper limb usually supraclavicular is the grandfather, or it's called the spinal of upper limb. So this is perfect. Okay, and if there is no contraindication with reference to phrenic nerve involvement, or you are using some of the techniques to have some phrenic sparing, supraclavicular is the best block, which will cover whole of the upper limb in a much better way than any other block. Yes, for shoulder surgery, interscalene block, along with this supraclavicular superficial cervical plexus, because some of the nerves which are going towards the shoulder area are not from brachial plexus, they are coming from the cervical plexus. You need to block those nerves. Okay. uh, Infiltration of local anesthetic between the popliteal artery and the capsule of the knee. Thanks a lot, Dr. Salma. Okay, it's a motor technique. Thanks a lot for my for recalling and helping me out. So interscalene plus superficial cervical plexus block just under the sternocleidomastoid is covering a good analgesia for shoulder. Here also there are certain techniques which will be avoiding the phrenic nerve, and I'm not very expert in it. Unfortunately, I will try to give you some information about it. You can read about shoulder nerve, block, shoulder surgery, analgesia, motor sparing, and phrenic nerve sparing. Okay, so they are very good for post-operative pain relief. Okay. Similarly, here you remember one thing, that musculocutaneous nerve is spared in a number of blocks. Okay, interscalene block it can be sorry, it can be missed in supraclavicular even. Okay. But it can be missed in of course infraclavicular. Okay. And in axillary block, you need to block it separately in the coracobrachial vessel. Okay. So you need to block, because musculocutaneous nerve is important in addition to intercostobrachial nerve and medial cutaneous nerve of arm for the tourniquet here. Just like lateral femoral cutaneous nerve, you need to cover when you are giving tourniquet for the lower limb. Here, intercostobrachial nerve, medial cutaneous nerve of arm, and musculocutaneous nerve. These three nerves are mandatory if you want to pain relief for the tourniquet. This is very important, okay? Because otherwise, if you are going towards the hand, axillary block, people like it because axillary block, there are too much advantages with reference to no phrenic nerve involvement, okay? Individual nerves you are blocking. But personally speaking, the problem, what are I will be telling you the practical problems, that because if you are giving it in awake patient, you need more analgesia of the subcutaneous area, because you need to manipulate the needles in various directions. Okay, so it is more painful, because in supraclavicular you are just doing one pop and you are blocking it everything. You don't need to manipulate the needle as much as you do in axillary block. Okay, so that's a problem. And infraclavicular block, especially the technique, the UL technique, there are more chances of pneumothorax. However, there is another coracoid technique. I don't do infraclavicular block, so I don't have much experience about it. But there is a technique which is a little lateral, and it is avoiding phrenic nerve as well as less chances of pneumothorax. So infraclavicular block can do the same things which axillary block is doing. Okay, in a better way, but it's a deep block. You need more experience in identifying the structures, and if you are doing it in obese patient, then it will be a problem. Okay, so these are some basic points about it. Similarly, IVRA, as I told you, it's a terrible block. Nobody use it in modern anesthesia. There is no need for IVRA. Okay, but still you should be knowing how to do the tourniquet, how to calculate the dose, prilocaine, and methemoglobinemia. They will ask you about it. How much tourniquet pressure, proximal cuff, in distal cuff. I don't want to waste time in it. Okay, so similarly, now few words about PEX block and the tab block. Okay, these are all compartment blocks. I don't remember the exact landmarks. One is between this pectoralis major and pectoralis minor. One is between pectoral. I don't remember the exact landmarks. But PEX blocks are for thoracic, abdominal thoracic surgery, breast clearance, axillary clearance. You need to have combination of PEX 1, PEX 2, and serratus anterior. Okay, tab block. The limitation of tab block is, remember one thing. The limitation, it does not give visceral pain relief. Okay, so for visceral pain relief, you need to give something else. So yesterday someone was asking tab block versus quadratus QL block. Okay, so the QL block also give visceral. So this is the advantage of this technique. Okay, so compartment blocks, there the problem is that you should be identifying that compartment in a nice way. Otherwise, you will inject in some other area, and unfortunately, you will not get the desired result. So that is the challenge which you face in compartment blocks. Okay, so similarly, you can have a look on various uh, trunk blocks. You should be knowing the rectus. There is one rectus sheath block. There is tab block. Okay, so you can uh, find a lot of information here in the Google Drive link which I have made. Okay, so erector spiny block, breast surface analgesia. This is also the you should be knowing. Okay, and here you will get a very good concept about it. So I have given you in my discussion, but whatever I have informed you in last 50 minutes, my basic aim is to give you a concept. So if you just think what we have discussed up till now, we have talked about the safety, we have talked about the calculation, we have talked about the concentration, we have talked about the basic concept, what you need to cover for upper limb, for lower limb, For trunk, you need to have both in the abdominal. If you are doing the abdominal surgeries, post-operative pain, remember one thing: the visceral pain you can cover with some adjuncts. The advantage of giving these, either it is stab block or either it is local, even local infiltration. The advantage will be that it will give a very good somatic pain. Somatic pain will be covered very nicely. So it will significantly reduce the requirement of opioids. So that's the advantage. Okay. So I will tell two more things and we will wrap up our discussion. One thing is with reference to the concept of multimodal analgesia and use of like regional anesthesia techniques with reference to multimodal. Actually, there are there are four steps of pain. So one is transduction, one is transmission, the third one is modulation, and the fourth one is perception. Okay. So actually, if you use this word, nip the evil in the bud. If you block the transduction and transmission, actually the pain relief will be much better way. So even if you have given a lot of opioids, if you give a local infiltration, local anesthesia infiltration, wherever you are, whatever surgery you are going, if you put some local in infiltration before surgery, remember one thing, because people don't do it, and this is a message to all of you: try to request the surgeon to have local infiltration at the skin with lidocaine. Okay, because lidocaine effect will come quickly and it will give a quicker relief before in CN there will be analgesia. Okay, so it will block the transduction and transmission. So this is very important. Try to make a habit, try to request the surgeon to have lidocaine infiltration wherever they are giving NCN. Even they are putting the trocar, request them. Even if they are giving the NCN, request them to give lidocaine. Even if this concept you use it in any other surgery, even local jelly, they are doing any cystoscopy, request them to have, because they use jelly only for lubrication. They are not interested in achieving any analgesia. But this is a message for you, all of you. Please request them to have local anesthesia. Even you are doing an ERCP, try to have very good gargles, because what will happen? They are saying we are giving GA, so you will give opioids. No need for local infiltration. No, please request them. So this make it a habit. Even they are putting the pins in the neurocraniotomy. Try to have scalp block, because scalp block will also reduce the pain. Okay. So these are the basic concepts which I have given you with reference to this is, yes, preemptive analgesia. Preemptive, this is what is called as preemptive analgesia. Like you preempt, like there is a forecast of rain, so you are taking the umbrella with you. So this is the concept of preemptive analgesia. So this will give a very good pain relief overall, and the surgical the sympathetic response will be blunt. Okay. So in addition to paracetamol, NSAID, opioids, dexmedetomidine, ketamine, if you use local infiltration, it will be a cherry on the cake. So it will be a very, very nice thing. So this is a message for all of you. Try to seduce the surgeons to allow you to have this, because surgeons will never rather I tried one day and the surgeon was saying, you are interrupting me, nobody else asked. So this is a message, global message to all of you. Try to have local infiltration or local use of local analgesia anywhere. On a lighter note, once I once I asked, we will ask the patient, we will give you local anesthesia. So he said, no, I don't want local anesthesia, I want international anesthesia. Okay. So he took it in a different way. He don't want local, he want international. So then I explained to him that local means what local. So this is on a lighter note. Okay, so as I promised to you, 5 minutes more with reference to or few words about anticoagulation and antiplatelets. Because it's a very big topic, I will just try to give you a basic idea. There are two different things which we are using. Either we are using heparin or low molecular weight heparin, or the newer medications. I don't remember anything. You have to open Google and just see how much is the duration of action. Okay, how much is the duration of action of those medication, and you need at least 3 to 4 half lives for its effect to vanish fully. Okay, 50%, then 25%, then 12.5%, and then 6.25%. Try to understand this concept of 4 to 5 half lives. You should be knowing that whenever you are giving any medication, you should be knowing the how much half lives it will be covering. Okay, so this is so heparin usually you need to stop it 4 to 6 hours. For low molecular weight heparins, if it is in prophylactic dose, you need to stop it in 12 hours. Prophylactic dose means once OD, and therapeutic dose is BD. Okay, so if the patient is taking therapeutic dose, you need to stop it 24 hours before giving central nunaxial block and even any deep block. Yes, there is a controversy. Some people will say if you are using ultrasound and you are giving superficial block, you can give it, but the thing is that it's not 100% safe. If you in the exam point of view, please tell them it's you will do a smart answer, risk versus benefit. You will do risk versus benefit, and only then you will decide whether you have to use that technique or not. Okay, don't take a risk in the exam. You don't need to prove that you are a champion. You just have to give a safety profile. So whenever you have any doubt, you will use this word, and this is the smart answer. Sir, I will outweigh risk versus benefit, because even yes, there are recommendation, people are using it, but there is also always a risk. So unless it's strongly indicated and there are too many benefits, you will not do it. Okay, so this is because ultrasound is not 100% that you will not have a vascular and bleeding and hematoma. So you should never take a chance. Okay, so this is with reference to heparin and low molecular weight heparins, and the other medication which people are there, because there are very new advanced clopidogrel and NSAIDs and aspirin. Again, I tell you something. Practically, they say aspirin, no problem. Sorry, academically. But practically, I think, again, I will tell you for a safer anesthesia, if the patient is taking aspirin, because sometimes they change the recommendations according to their population. But practically, I am telling you again, this is not in academic exam point of view. In exam point of view, patient is taking NSAIDs, patient is taking aspirin, you have no problem. Even if the patient is taking a lot of garlic, this is can cause platelet dysfunction. Okay, so any condition in which there is platelet dysfunction, highlightly another important thing is CRF. In the CRF, patient has platelet dysfunction, the number will be fine, the PT-INR will be fine, but remember one thing, this is platelet function, not the number, not the INR. It's a platelet stickiness. The patient platelets are not very good because of vascular dysfunction. The combination of von Willebrand factor and platelet and tissue factor, the coordination is not there. So patient can bleed a lot more than expected. So again, risk versus benefit. You can use this thing that is still there is, or either you will do CTBT or along with platelet function assay. Normally, we never use these things, but you need to know the platelet function, not the numbers. Platelet dysfunction will be the problem. So you need to verify the platelet functions are okay. Okay. So CTBT for this platelet with reference to platelet, antiplatelet. Yes, theoretically, clopidogrel for 4 to 5 days, 5 days roughly, and NSAIDs and aspirin, no problem. If they are taking in a small dose, no problem. But practically, I tell you something, be careful. If the patient is taking aspirin chronically, because aspirin irreversibly block. Okay. So again, the problem is this one. And especially another thing, combination. If the patient is taking combination of clopidogrel and aspirin, even clopidogrel has been stopped for a certain time, then there will be more chances of bleeding. So be careful about it. So this is something important. The newer medication, whatever you find in the patient chart, Google it and find how much is the duration and how much time you need to stop it. So this is a basic concept about use of an regional anesthesia with patient with the liver problem or kidney problem or patient taking anticoagulants. Liver, again, the same thing will occur. Not only the INR, not only the APTT. You should be thinking about the function. Okay. So platelet dysfunction, yes, The category will be the patient is chronically on dialysis. So dialysis improve platelet function. Okay. So you can say that if the patient is on regular dialysis and there is no parent history of oozing or bleeding tendency, so yes, you can take a chance. Okay, but in the examiner, just whisper in the ears of the examiner that you know this point, that always outweigh risk versus benefit, and there is always a chance of bleeding in these patients. Okay, so that's it. What I wanted to tell all of you. This is the maybe some people will say this is not what you were expecting, but this is, believe me, if you know this knowledge of regional anesthesia, practically as well as in exam point of view, this knowledge, if you know the remaining thing, you can cram very easily. What are the landmarks? What are the and yes, another I forgot endpoints. Usually, you should be knowing the endpoints. Endpoints means what will happen when you achieve a block. There may be autonomic block, so you should be knowing how to do the autonomic check, because you need to check the autonomic nervous system either with the temperature or with the fall of BP. This will be an apparent. This is with reference to central neuraxial block mode. Sensory by the touch, and the motor. For motor, you need to know the see what is the you see sometimes your mind is washed. What is the scoring system we use for the motor for spinal? Anyone, please? Inna lillah. I forgot.
Bromage chlorine, sir.
Bromage score.
Bromage.
Thanks a lot. So it's a bromage scale. Okay. So motor with the bromage scale, sensory and autonomic. So you should be knowing about it. And another, then there will be certain twitching of the muscles or certain reflexes you will find in upper limb. Okay. So you should be knowing the endpoints, the safety, the combination. So this was all I wanted to tell you. Overall concept of regional anesthesia. Okay. So the rest of the things you can easily grab. If you have this basic concept, even in any block you come, you should be knowing these things. Said whenever they are asking you any block, you tell about the safety things, and the rest will be only the block landmarks or block technique specifically. Okay. So thank you very much. Tomorrow, actually, our one of our senior professor will be taking a class. So I will also attending that class. So because he will be taking class in our native language, I'm afraid not much benefit will be given to the international speakers. And so day after tomorrow, maybe any of the unit I will try to cover, maybe pain or anything, I will just inform. Okay. So thanks a lot, all of you, for joining me, giving me honors. And later on, you want to ask any question, you are welcome to ask anytime. You can contact me through WhatsApp. And before just signing out, I will just show you that in the regional anesthesia, uh, I have done this, even the separate techniques and separate other. Oh, just a, just a second, let me show you. So here in the playlist of regional anesthesia and pain, I have done the basic concepts number of times, and even you will find some of the separately. Okay, so separate concept of multimodal, some of the topics of pain. Okay, IV lidocaine as an analgesic. Okay, that some of the topic by one of our senior colleague in Canada, and then circumcision, knee surgery, hip surgery. Okay, so you will find a number of important things here. You can have a look here. Okay, so thank you very much for your time, and inshallah we will meet day after tomorrow. Bye bye. Yes, on one more thing we call finishing. Please make your own analgesia plan for all surgeries, all common surgeries which you do. Okay, and in this actually, just a second, let me show you. This is important thing which actually just struck my mind. So let me tell you before I finish, just a second please, that make your I have actually made a list of the surgeries. It's a very terrible list, terrible and long list, but actually the original procedures are not that much big. So there are so many common things. So have a look on this list, okay, and try to have some information about it. Not details, not details. Oh, then don't be afraid that, oh, Dr. Zishan, how we will be finished. But it's actually number of things are common. Number of things are common. But as a good anesthetist, and even for exam, try to have the basic concept with this one. Okay. Deep into the surgeries according to, and then surgical urgency, surgical risks, bleeding risk, and with reference to analgesia, which we have, that what are where the NCN is done and what are the required things. So you should be knowing about this thing. So you can just have a look on these surgeries with this window. Okay. If you open these windows for all these surgeries, one of the component of your exam will be covered in a very nice way. Okay. So thank you very much. Bye bye.